Our next speaker is Dr. Alexandra Yonts. She is an attending physician in the Division of Infectious Diseases at Children's National and an assistant professor of pediatrics at the George Washington University School of Medicine and Health Sciences. She received her medical degree from the University of Nebraska College of Medicine, did her pediatric residency and was a chief resident at UC Davis, and completed her pediatric infectious diseases fellowship in Washington as part of a combined Children's National FDA program. Her main research interests are in the areas of vaccines and novel antimicrobial therapies, post-infectious neuroinflammatory disorders such as acute flaccid myelitis, in medical staff and trainee well-being, and antimicrobial stewardship. So Dr. Yonts, thank you for being part of the symposium today. We're looking forward to hearing your talk on the long haul, what we have learned and what we are doing for children with post-acute sequelae of COVID, or PASC. Floor is yours.
Thank you so much for that great introduction, Dr. Lane. And I must say, I am humbled to be in such esteemed company with two of my mentors and with what I'm going to call a legitimate ID celebrity in Dr. Hotez. So thank you for having me. This is going to be a little bit different talk touching on the clinical experience that we've had at Children's National in our post-acute sequelae of COVID clinic, a little bit of data from that clinic and a lot of discussion and ideas about where we can go in the future, looking at these clinical questions that sort of parallel the PoCo study that Roberta and Gina are doing. All right, so I'm gonna go quickly through some definitions to make sure we all know what we're talking about, because PASC has become sort of a larger umbrella term in a lot of ways. Touch on the epidemiology of this in the pediatric setting, talk about our specific clinic population and what we've seen in the year that our clinic has been up and running. Touch on what we do for management and evaluation of these patients, and then end with some potential clinical research questions and sort of future therapies and management that have been discussed in the literature. So there is a spectrum of post-COVID conditions, and we've talked about all of those throughout the various sessions in today's talk so far. I kind of conceptualize this as a continuum, starting with those symptoms that go along with acute infection in the 4 weeks or so after, initial positive testing and symptom onset, the lingering cough, sometimes the fevers, those things that we might see with other illnesses that hang on a little bit longer in those with COVID, but really kind of fit with the initial pattern of symptoms. And then following that, within the initial 12 weeks after COVID, we see new onset of some later term sequelae. And best example of that in the pediatric population would be MIS-C, which usually pops up anywhere between 3 to 7 weeks after initial infection, kind of comes out of the blue with this hyperinflammatory response. And those I think of as a different bucket of conditions than what I'm going to be spending this talk describing, which is really the more persistent and chronic symptoms that either hang on from the infection at initial presentation or continue or develop within a month or so after that infection. So this is what has been colloquially referred to as like the long hauler group or long COVID. There is a definition of post-acute sequelae of COVID or long COVID that has been put forth by the WHO through consensus definition. And granted, this is for adults. However, I think this is a workable definition for looking into this question in the pediatric population. And they define this long COVID as a post-COVID condition that's been persisting for at least 2 months, that started or continued 12 weeks from the initial infection, with symptoms that may fluctuate or relapse over time, but have been persistent throughout that space and time periodically. Has an impact on everyday functioning, which is an important aspect of this, and that there is a history of probable or confirmed SARS-CoV-2 infection, either through lab testing or very strong clinical criteria with known contacts. And the last piece of this is, with so many of these conditions, that their symptoms cannot be explained by an alternative diagnosis. And that is one of the things that we can do in sort of initial workup of these kids, and I'll touch on that in my evaluation section. So looking at all of that and that definition, how do we pull this together? So there have been numerous attempts and numerous papers published on all of the symptoms that persist after COVID in adults and children. One of the earliest studies was done by a group out of the UK called Long COVID Kids that has actually been one of the biggest advocates in pushing forward any sort of evaluation, research, clinical progress in the long COVID population. And they did a survey with families, so flawed in terms of potential study design, but really were able to isolate a very long list of symptoms. As you can see in this image on the right, those are all the different symptoms that were presented by parents in this survey response. And they had kids in this study that had been symptomatic for 8 months after their initial infection, reporting 4 or more symptoms in a great deal of cases. So it really is, it's a very broad problem. And one of the things that are being worked on in the greater long COVID community is narrowing down or parsing out these symptoms into different symptom clusters, so to speak. So a great paper that was published by Kenny et al. In March actually identified through cluster analysis of self-reported symptoms, sort of 3 different groups. There's like a pain group where patients primarily presented with joint pain, myalgia, GI symptoms, a cardiac group, or what I like to see from our patient population as the POTS group or dysautonomia group, in which chest pain, palpitations, shortness of breath were the predominant symptoms that came together. And then sort of this third mild group that didn't really have a major symptom that predominated in other, over another. And these, I think, suggest that there may be different processes going on with these patients, and give some areas to kind of tease out these different symptom clusters and get at the answers of what's actually causing the problem in these patients. But fatigue is the unifying symptom in all of these. And as you'll see in our clinic population, about 80%, so almost all of our patients do complain of fatigue as their primary symptom. I often get the question, what are the differences between pediatric and adult post-COVID conditions? And this actually correlates really well with Roberta and Gina's findings in the PoCo study, is that kids after COVID and in the long COVID clinic really do tend to present more frequently with abdominal or GI symptoms. And so this is not just in adults versus kids, but also kids with COVID versus kids without COVID. They're thankfully also less likely to have pulmonary complications, likely due to less severe initial disease, as most of these children are mild or asymptomatic with their initial SARS-CoV-2 infection or mild COVID. So transitioning, briefly touch on epidemiology. This is a very contentious issue in all parts of long COVID research, because studies have different definitions, different study types. Data is often skewed to those hospitalized because of easier data collection. And so there's been a wide range from the beginning, estimates between 4 and 66% of children who have had COVID meeting the definition for PASC. As time has gone on and studies have been narrowing a little bit, I think it is likely that this is closer to 10% or even 5 to 15 in that range. But we still need to continue to look into narrowing these definitions to get at least, even if it's broken into phenotypes or subtypes of COVID, coalescing all of those findings together. I like to point out that adolescents in the literature and in our clinic present much more frequently than young children, but a lot of this may be reporting bias. As someone mentioned in the chat, the main symptoms of fatigue and sort of brain fog are very, sort of subjective symptoms, and it may be harder for younger children to voice that they're experiencing that, but they may still have some abnormalities that keen parents could pick up on, but may be subtle. So they're obviously having more objective measures to look at this is an important thing. This slide, I just wanted to highlight a few of our patients who have very bravely put their stories forward and been involved in the media and in advocacy to get the word out about COVID in children and long COVID in children, because there's still a lot of the world that believes that this COVID is not a problem for the pediatric population. So this is Messiah. He was actually our very first patient in our COVID clinic, Ava, who is 19. And then it's not a picture, but one of our 9-year-old patients actually wrote a book about his experience with COVID and then subsequently long COVID, which is adorable. So he is this little boy seated in the middle of the picture. So I wanted to touch on the data from Children's National Post-COVID Program Clinic. So a bit about our clinic. Our clinic is a referral-based clinic. We have a central email that is included on a slide somewhere later in this presentation that we accept patient referrals from clinics and other physicians. And then once we get that information, we have a great team of very dedicated part-time case managers who split up the work and call these families to do an intake screening. We have a standardized form that runs through different symptoms to kind of determine what their subspecialist needs would be for their clinic visit. We have a weekly meeting as a clinic team to go sort of over that and scheduling and setting up sort of beyond the core subspecialists. So in our multidisciplinary clinic, all patients see ID, psychology, and PM&R. But we have additional relationships and connections and sometimes on-site visits at the day of their main appointment with GI, neurology, pain medicine, rheumatology, cardiology, and pulmonary medicine. So that's sort of the workflow. So it's very labor intensive, but really helps tailor the ideal one-stop approach to evaluation for these kids that have been passed around from clinic to clinic otherwise. So here is our clinic by the numbers. So we have seen 70 patients since the post-COVID program clinic opened in May of 2021. And we are only getting busier. So we now are over 250 referrals or inquiries. We're up to 6 to 10 new referrals per week. So keeping our case managers very busy and I'm currently booking patients into September. The average age of our patients is 12 years with a range of 2 to 20. So really all age groups in the pediatric population. There's a slight predominance for self-identified females over males in the clinic. And most of our patients are from the District, Maryland, Virginia area, but we have had referrals from other states looking for a focused long COVID clinic. And in many cases, patients that are enrolling in the PoCo study with either the NIH or at Children's National and have some sort of clinical need to be addressed beyond being in an observational study. So there's nice crosstalk between Roberta and Gina's program and this clinic. We have demographic information that is predominantly Caucasian, with a much smaller than expected representation of Black children, as well as Latin and Hispanic patients as well, which is an area of potentially further research. On average, patients present about 219 days out from their initial acute COVID-19 infection, with a range of 34 to 714. So 34 days would not be someone we would see in clinic anymore. We actually now stick to the 12 weeks of symptoms due to having such a crowded clinic and limited resources. But early on, we were able to accommodate people that were much closer to their acute infection. And interesting, looking at that range of symptoms, as I mentioned, there are over 200 that have been mentioned in the literature with long COVID. Our patients on average have 10 symptoms or complaints, with a range from 2 to 22, so sort of a pan-positive intake form. Okay, so and speaking of that, here are the presenting symptoms at intake for our patients. As I mentioned, 80% of them do complain of fatigue as their primary issue, with high percentages of decreased appetite, decreased exercise tolerance, and headache, all in the range of about 70%. And then over half the patients also complain of abdominal pain and brain fog. So tracking along with what we've seen in the even children with survivors of COVID, whether or not they're considered long COVID, but some of those patients are in Roberta's study. This is the slide I was looking for to introduce our clinic. So it is a multidisciplinary clinic. We see children up to the age of 21 who are 12 weeks out from infection and have at least one prolonged symptom or new late onset symptom and have lab confirmation or contact with lab confirmed COVID by RT-PCR antigen or serology, which will often ask for a nucleocapsid IgG to confirm infection rather than vaccination. We currently have appointments on Wednesday afternoons, and we have 3 appointment slots, so we were able to expand the clinic a little bit, and they're typically 2-hour appointments where they cycle through several different subspecialists during that visit. That's information on how to refer. As I mentioned, there's an email that is readily available at the Children's National website. So there is some guidance that has been put out by the CDC for care of those with post-COVID conditions. But as you might note, it was last updated in June of 2014. So there really hasn't been a lot of evolution in this area, but the principles in general apply quite well, that patients should have a stepwise workup, that focus should be on shared decision-making and goal setting with the patient and the family. So prioritizing what is the most disruptive symptom in your life, what is your goal for this visit for overall improvement, and that multidisciplinary clinics are very beneficial in this role. Initially, we were maybe one of a dozen pediatric clinics that would see long COVID patients. I think that number has grown a bit, although some are clinics in name only and don't actually have multidisciplinary care, simply set up a referral network for other patients. So here is just a list, again, put out by the CDC of potential lab evaluations. I find this more helpful when referring to primary care providers or physicians that may be having first contact with the patient to help rule out other conditions that may be causing fatigue or some of the more nonspecific symptoms. So in particular, thyroid disease, ongoing EBV infection, anemia, those sorts of things. And then once symptoms have become more persistent or progressive, there's some other evaluations that they recommend that I can tell you anecdotally have all been negative in our population. But again, to look for rheumatologic disease as an underlying issue. We use similar assessment tools to what was described in the PoCo study. So we do a 6-minute walk test, which could be used to clinically trend patient improvement or worsening. And we associate with cardiology, who will do more formalized dysautonomia testing. So beyond sort of orthostatic vital signs, but tilt table testing, and as needed, refer to pulmonology and cardiology for clinical tests, PFTs, and cardiac imaging. So there are a lot of questions that need to be answered in a systematic, scientific way for patients suffering with long COVID. There's a lot of chatter out there about potential strategies in the long COVID community. There is a bit of just getting everyone on the same page has been a challenge. So we have priorities that we would like to discuss in our clinic, which moving forward are sort of more focused on the clinical management and really improvement of the process of getting these kids evaluated and managed. So would like to further explore some specialty prioritization, really assess the impact of long COVID on school attendance, and subsequently parental, missed work, impact on transition out of the school age into college, all of these major life events that children are going through, and to look at that question of, are there racial disparities and issues of access in a long COVID clinic? As I briefly touched on, we've not seen near as many Black and Latinx patients in our clinic, given what we know about how those communities were affected by acute COVID. So suspect that there is definitely a disconnect with maybe the physicians working in those areas and making the referral, or some other level of access that we would like to resolve. I think risk factors for the PASC community for pediatric patients is something we'd really like to look into. There's been a little bit of data on that in the adult population that's been promising and may apply to children, but we need to confirm those results. And then one of the biggest things, which is one of the hardest asks, is more targeted testing and tools sort of beyond the basic evaluation. So we all know all of these kids get CBCs and CRPs and basic inflammatory markers, and most of them are normal, but they're still having symptoms and something is clearly wrong. So this is where kind of the rubber meets the road from some smaller bench labs that have been doing work looking at platelet aggregation and microclots, and confirming that in various ways, including fluorescent microscopy, serum amyloid levels, mitochondrial function assessments. And then one study in particular that is very promising, I'm working with our pain medicine colleagues to look at sort of pain responses as a surrogate for small fiber neuropathy, which has been demonstrated in other post-infectious myalgia type of syndromes. And so would be an objective marker from tissue if we were to correlate that with these patients. And then a potential role for clinical trials in looking at the role of supplements. That's been something that's been suggested and used in a lot of patients because there aren't any approved medications specifically for this condition. And likely it's a multifactorial problem that's going to require several different approaches, antiviral therapies and anti-inflammatory treatments potentially as well. We will skip what I was going to talk about, which was just really highlighting this promising work from our pain medicine team. So Julia Finkel and her research teams, Olivia Lamana and Kevin Jackson. This was going to be a poster at the symposium, but obviously since we converted to virtual, had to back off, but I think very promising work. So hopefully they'll get a chance to talk about it in the future. And then my acknowledgements were just, this is definitely takes a village. I'm very grateful for our large team of case managers that has been able to help and sort of donate little bits of their time, since this is an unfunded clinic, as well as the providers that have been able to carve away, one afternoon per week from their normal clinical duties to see patients, in particular Justin Burton from Physical Medicine and Rehabilitation, Linda Herbert, our GI team with Alexis Gervais and Sona Segal, and our ID outpatient team, as well as rheumatology and Abby Bosk. So very grateful. There's a lot to do, a lot of work, but I think it's been a very satisfying clinical presentation, and sorry that this was out of order and so scattered, but thank you for listening, and I'll try to answer your questions.
No, thanks very much. And as with the other talks, please put the Q&As into the Q&A box, and then I would ask the speakers to keep an eye on the Q&A box and answer as they come. I'm just going to ask you one quick question, because just curiosity. What's the wait time for someone who wants to come to be seen in the clinic?
Yeah, so currently it is about 3 months. We have started doing kind of a triage type of process with kids that are either have been longer since their initial COVID infection. So talking like fall 2021, or are completely out of school, completely virtual school, are more sort of disabled. But we really would like to expand the clinic so that we can see kids faster, which is just going to require funding. So
thanks very much. Yeah, no, I would just add one observation from the adult side is, just as we saw early in the COVID pandemic, a whole array of things being proposed as treatment. I mean, you see the same thing beginning to happen now for long COVID or PASC, and some of the same players showing up, such as ivermectin. So it really is an area where I think robust research is going to be needed. And I'm glad to see there are some, clinics focusing objectively, some research being done. Heart, Lung, and Blood and Neurology Institutes have the large national RECOVER study. So hopefully we'll get data, with time that will hopefully identify some therapeutic targets.